Trauma assessment. We're going to do this pretty broad. Right? I'm not going to have a specific patient. In the PED scenario, I'll have more of a specific patient. But for trauma assessment, it's quick. We got to figure out what's wrong, what is killing this patient, what our trauma alert criteria is, obviously, and then fix it real quick, get in a truck, do more vitals, any other treatments, assessments we need to do, we're out. Trauma's quick, 10 minutes on scene, golden hour trauma, we want to get them to the ER, into the trauma bay as quick as possible, right? So we know what to do when we walk up, okay? BSI, scene safe, number and location of patients. When you ask that, you're gonna get an answer. Yeah, scene is safe. You got one patient, we're gonna go broad with this, laying on the ground, possibly ejected from his vehicle after an accident. Okay? From there, pick MOI. We know this is MOI. We're going to consider C-spine. We'll get additional resources, PD, and an engine. Okay? You know in your trauma scenarios, they're almost always, if not always, going to need a C-collar. So plan on using it. Okay? You guys have 4 people, including yourself in the scenario. You've got enough hands. All right? So we got all that cleared up. We know what we're going to. All right? Walk up. Next thing we're going to say, what's my general impression of the patient? Do I have any obvious life threats? Okay? So let's say we have one patient on the ground, supine, and we have no obvious life threats. Okay? No obvious life threats. Cool. From there, we're going to walk up. The more you talk as a student getting tested, the better you're going to do, because that lets whoever's grading you know that you know what you're talking about. All right? The more you speak, the more detailed you are in your questions and your exam, the better you're going to sound. Okay? So, you know the general impression of the patient. He's supine on the ground. We don't have any obvious life threats. All right, I'm going to walk up to the patient. I'm going to have my EMT hold C-spine. As I walk up to the patient, I'm going to ask what happened. While I'm asking him what happened, I'm going to check a pulse. I'm going to look at his pupils. And I'm going to pay attention to my respiration rate. All right? If he doesn't answer the question, then that gives us 2 answers already. If he can't answer you, we're going to go with a sternal rub real quick, right? Nothing. We know we need to check a carotid pulse instead of a radial pulse. But we also know his GCS is going to be less than 12 if we don't get a good answer out of him, or if there's no response at all, then we know it's even less, okay? So it's going to be under 12 to a 3 depending on his response, all right? You also asked about pupils, okay? By asking about pupils, you're able to tell, okay, do I have a head injury? Is one of them blown? Do I have constricted pupils? Are they reacting, right? I'm checking the circulation. We already talked about that, so it's going to give you an idea of his pulse rate. If he has a tachycardic pulse, we know he's probably in some type of compensated shock. If he doesn't have a radial pulse, but he has a tachycardic carotid pulse, that's not good. There's a trauma alert, right? So we got to, initially when we walk in, figure out what our trauma alert is, and you can do it by asking those questions. And the last question that you asked, I'm paying attention to his respiration rate. Is it irregular? Is it rapid? Labored? Do I see symmetrical chest rise and fall? Any of that stuff is going to give you an answer to a trauma alert, right? Because if I have a bad GCS under 12, trauma alert, okay? If I have irregular respirations, labored, all right, well, you're going to say airway. Go ahead and get me lung sounds and a respiration rate, and I'm going to expose the patient to check. All right? You're getting your answers to your trauma alert and what's wrong. When you walk up and ask you ask that question, what's happening with my patient? How does he respond? What's going on, man? What happened? While I'm waiting for him to respond, I'm looking at his pupils, I'm checking the pulse, and I'm paying attention to my respiration. And I'm also paying attention to my skin condition. The more you talk, the better. We can't answer you until you stop talking, okay? So be specific in your questions and tell us what you're looking for, all right? If I tell you that this guy, again, is unconscious, he doesn't respond to you speaking, all right? Sternal rub, nothing. I'm checking the carotid pulse, nothing. All right, GCS less than 12, good to go. There's my trauma. From there, you obviously are probably going to have some type of condition with the pupils, right? We're thinking if this is a trauma, it's probably going to have a blown pupil. From all the scenarios we've been given, you should know where this is leading, all right? If he does respond, let's say he tells you, and just to go back to that real quick, just because you don't have a blown pupil doesn't mean we don't have some type of TBI, right? What else do we need to check for? CSF looking from the ears, from the nose, as well as battle signs, okay? And again, you got somebody holding C-spine this time. If he does respond, let's say he tells you, all right, I can't breathe, my chest hurts really bad. All right, airway again. Get on respirations while I expose the patient, okay? We're gonna expose, look at the chest. Do I see any injuries to the chest? Any flail segments, symmetrical rise and fall, things like that. If he tells you he's having trouble breathing and you notice any of those things, what we have? Active airway assistance, okay? So we gotta call our trauma alert quickly. From there, there's not much we're gonna do in the field, all right? C-collar, do a quick head to toe. Again, we said there's no light threats. You can go through that real quick. You got nothing, all right, I don't see anything. We got the C-collar on. Let's roll them before we get them on the backboard. Not everybody uses backboards, but for NREMT, we're still using the backboard. So just keep that in mind. All right, we log roll the patient. I'm gonna check the back real quick. Just gonna do a quick exam, check for stair stepping, checking the flanks, any bruises, check do I see any flail segments on the back, things like that. All right, just a quick assessment. If there's no penetrating injuries or any of the last things that I just stated, we're good to go. Put them on, get them in the truck. Then we can start connecting them to our life pack. We've already called the trauma alert, whatever this might be. So now we can start worrying about the life pack, right? In the field, any type of severe trauma, we're just doing quick BLS stuff, okay? We can do all of the the paramedics EMS in the back. When we get on scene, we gotta figure out what's wrong. We gotta figure out what's wrong quickly. And we gotta get in the truck so we can do our treatment and get them to the hospital. Because again, we don't wanna be there more than 10 minutes, okay? You got 2 minutes to call your trauma alert. So you get them in the truck. Let's keep going with the breathing, and then we'll go back to if he was unconscious. But for now, let's say he's conscious, tells you he flew out of his car, and he's got chest pain, irregular respirations. We'll say the left side from your assessment revealed that the left side is absent lung sounds. We have asymmetry, or we don't have good chest rise and fall, right? We got irregular respirations, and the right side is clear. Okay, you also see a flail segment on the left side. That's giving you some very obvious signs. It's going to be either a pneumo or a hemopneumo. Okay, so we start hooking them up to the life pack. Get our blood pressure. Okay, turn it on. Get my SpO2 on there. All right. Get my 4 lead. Remember, when you take these wires out, this is your cheat sheet right here. If you feel like you're in any type of scenario, once you get these connected, this is your cheat sheet, right? I can look at these wires, follow them back. Did I get the answer or not, right? Did I figure out what my heart rate 4 lead shows on the monitor? Oh, okay, let me look at this. Yeah, okay, I did. Blood pressure, same thing. Did I get a blood pressure? Let me follow the wire back. SpO2, same thing. End tidal, same thing. Check it all, right? So you hook them up to the 4 lead. I don't have this set. Let's say it's 150, sinus tach. SpO2 comes back at 88% with the BVM going, right? The next thing I know is the lead. I'm gonna need to start delegating, right? So I need to have my med guy give me an IV, right? From there, I'm gonna get my lung sounds in and check, do I have hypo or hyperresonance, right? If I have hyporesonance, think hemopneumo, low blood, hypovolemia, I'm not going to do anything for that, right? I cannot do a needle decompression. We're not doing a hole in a hole, okay? If we have imminent arrest later on, then we can think about a finger thoracostomy, but most of the lab, we're not going to be having you do that, right? But let's say we get hyperresonance, okay? That's a tension pneumo. Hyperresonance, tension pneumo, we know we got a needle decompress, okay? We get our 2 large bore IVs established. Now we can start checking vitals, doing our reassessment. What's my end tidal? Has my SpO2 gone up after I've done the needle decompression? How's his breathing? How does he feel? Is he still in pain? Is it more regular chest rise and fall now? What do we got? Just keep reassessing. We're constantly reassessing. And then obviously we want to, at some point in this scenario, once we get into the truck, start figuring out our sample. Okay, signs and symptoms we know. You got thrown out of the vehicle. And he's having trouble breathing. Attention. Allergies, give him an answer, meds, past medical history. Last oral intake, again, we know the event leading up to the storm in the vehicle. All right, we get our 2 large bore IVs, keep monitoring, and we can do our secondary detailed head to toe. Right, when you do the secondary detailed head to toe, be specific, okay? I wouldn't let another guy in your group do the secondary head to toe. You as the lead need to be doing that, because what if they miss something, right? You gotta pay attention to everything. We've already checked the back. We know there's no penetrating injuries. We had some bruises to the flanks. No stair stepping, no other flail segments no more over here, right? So during this secondary assessment, we can start treating some of the more minor things with my other guys. Flail segment, all right, let's patch that up a little bit. Get our bulky dressing on there. If we had any lax, breaks, anything like that, that weren't open fractures or affecting our pulse rate at all that we saw originally on scene, then we can start splitting those things up, doing wound care, things like that. But we've taken care of the major issue in this scenario specifically, right? And that is figuring out that we have a tension pneumothorax, need a needle decompress, right? Start doing my head to toe. All right, I'm checking for crepitus on the head. Do I have any blood on my gloves when I look? Do I see any lacerations? Same with the face. Again, I'm going to look at the pupils. Do I see any CSF leaking from the nose, ears, battle signs? Do I see any injuries inside of the mouth, any blood in the mouth, any missing teeth, things like that? All right, calm down. JVD, tracheal deviation. Is everything midline? All right, I'm checking my clavicles. Again, I'm checking for good chest rise and fall. Okay, any rib fractures, flail segments, things like that. Keep going down. I'm going to palpate and examine the abdomen. As I examine and palpate, is it soft, tender, non-rigid, rigid? What do I got? Right? Do a good assessment. Come to my pelvis. Remember, we don't rock the pelvis anymore. Just first press in. Any crepitus, any pain, ask your patient. Up and in, same questions. Any crepitus, and then you're asking the patient, do you have any pain upon that? All right, go to our legs. Checking, do I have any deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. If you say all that to me the first time, we just don't say, all right, I got decapitated here. You're going to sound better. The more you talk, the better, okay? So, if you've already stated that, then you can keep going with it. BTLS, all right, I don't have anything, no fractures, no lacerations, no penetrating injuries, whatever. All right, I'm going to check PMS. Do I have pulse motor sensation? Okay, same for this leg, and then same for the arms. I'm going to do all that all the way through, okay? We can reassess again if we need to, and then we go to the hospital, call it in, all right? Now, if you had, going back, like we were saying, what if we had an unconscious patient? All right, I got an unconscious patient, I walk up, he's laying on the ground, and I see bleeding from the head, right? Pretty heavy bleeding from the head. All right, I walk up, ask him a question, doesn't answer. Check a carotid while I do a sternum, okay? Doesn't answer, then I definitely have some type of TBI at this point, right? What's telling me I don't? I'm going to look at the pupils. I'm going to look for CSF, battle signs. Quick, easy. Do I have trismus of the jaw? If I have any of that, definite TBI, right? And when you're being tested in lab scenarios, it's going to correlate with what you find, right? Nobody's trying to trick you into anything. It's testing. We're not trying to trick you, all right? So let's say I tell you the left pupil is blown. You see CSF when you ask me that, and you have trismus of the jaw. Definite TBI, right? We got a traumatic brain injury here, herniation, okay? We have an axonal brain injury. What do we need to do, right? Well, again, if we're starting at the very beginning, we should have somebody on C-spine. We know this guy has to get into the truck quickly. We'll do the rest of our quick head to toe, make sure we got nothing else that we're missing, okay? Start bagging. He's not going to breathe, and if he's got trismus, he ain't going to take the opiate, okay? So we start bagging him, we're ready, we'll log roll real quick, check the back, okay, nothing, lay him on the backboard, get him in the truck. Now, what do we need? 2 large bore IVs, because I need to give TXA, Again, in this lab, I'm good to give them TXA and whole blood at the same time. For a head injury, some places might say, we don't want to give whole blood with just a head injury. Now, if you had this head injury and a leg amputation, there's no worry about increasing ICP by the added blood because we have a severe bleed down here. All right, so if we had a leg amputation too, we're going to throw a tourniquet on there before we get them on the backboard, then we'll get them in the truck. Right? Just figure out what you got and what we got to treat. Okay? Get them in the truck, and from there, let's start getting up 2 large bore IVs established. All right? We're going to need to do 2 things. First, I want to get this. What do you guys think would be first in your head right now while you're watching this? Is it more important for me to get TXA and a whole blood on, or address the fact that this guy's not breathing and he's got major hemorrhage? Okay? If I can get 2 IVs established real quick, I'm going to hang my 2 grams in a D5W with 50 D5W with TXA, put that on one side. All right, I got that going. Now I'm clotting that brain injury, right? Fibrinolysis is occurring. Now we got the clot going. All right, that's what we want. We got to stop that bleeding. Do I want to get whole blood just for a guy with a severe brain injury right now that is unable to breathe, with crappy respirations, if any, with trismus, or do I want to use this IV right now to start RSI? Well, I'm going to say let's probably RSI right now, right? We got to take control of this dude's airway, then we can start worrying about the blood. And I would say the exact same thing if we had the head injury with the amputation, okay? Because we are going to be clotting with that one line that's got TXA and whole blood, but then we got to RSI, okay? We got to get our rock, we got to get our ketamine, whatever you use. RSI this guy, take control of your airway, and then we can continue. We can add whole blood after that, do our secondary assessment connecting with vitals. But again, the main thing that's screwing everybody up on these is we're not doing a good initial assessment. Walk up to your patient, ask specific questions, okay, and tell me what you're looking at while that patient's answering. I'm looking at the pupils, I'm checking the pulse, I'm paying attention to the skin, and I'm also paying attention to his respirations, okay? Get your trauma alert, 2 minutes, basic from that.